Bismillah ar-Rahman ar-Rahim. I am Professor Abdelbaset Saleh, Head of Chest Department, Mansour University. My topics today about spirometry. Spirometry, one of the main tools we can use for diagnosis of different pulmonary disease. My objectives today to identify the component of pulmonary function. ازاي تتعرف على الكومبوننت بتاع البلمونري function. How can you identify component pulmonary function? Describe the indication. What is the indication? Develop stepwise approach for interpretation to recognize a common pattern, to apply this for information to patient care. If we have different tool, if we have different guideline, it is must be ended by to interpret, to implement this maneuver for our practice. Spirometry, what is the difference between spirometry and spirometer? Spirometer, this is spirometer, this is spirometer, and when you prescribe, you need what? You need spirometry. But spirometry to measure the airflow lung volumes during forced expiratory maneuver from full inspiration. But spirometer is the apparatus. Spirometer simple office based measure flow and volume. This is the history of spirometer. Started from 50s by drum like this, and this changes. We have this apparatus in our department in 1997. This body box and the disc spirometer, and this one is a so small disc spirometer, and this is also disc spirometer, small handheld spirometer. This can be used in different scales. When you go to manufacture, when you go to do survey from any place, you can save 500 or 1,000 patient. This is a different one. This also another tools we can use is named what? Big flow meter. The big flow meter is so small, so cheap. The maneuver tools or apparatus can use for the patient of bronchial asthma to follow up this patient. If the big flow meter for this patient is green, يعني above 80 to 100%, from 80 to 100% from the predicted for this patient, we notice that this patient in the green zone, we don't need any change in the medication. If the big flow meter between 50 to 80, so you can, this indicate caution. You must call me and I can change your medication. But if the big flow meter below 50% or less, the person best indication now for office visit, and I can re-examine you, and that's why your big flow meter dropped below 50. Why we perform this spirometer? We perform this spirometer for diagnosis, for follow-up or evaluation, for monitoring COPD patient, asthmatic patient, any patient with breathlessness. We can screen by using the spirometer, and we can add diffusion, we can add body box, we can add airway resistance, different maneuver to reach to the most final diagnosis. A screen work of force in occupational environment, assess fitness to dive, pre-employment and medical legal and pre-operative evaluation for the patient. We have some infection control policy to clean this spirometer before we doing it, and using the guideline for each apparatus. Spirometer technique. We have our worker, we have our technician, Mr. Muhammad and Ms. Ines can do one spirometer in front of the view. The patient can sit on this set. Sit must be hard, not to be soft. This is set to be hard, not to be soft. The patient with using clothes, not use tight clothes, no severe exercise before doing it. before doing it. After that, the technician, our technician, will enter the patient data. This patient data including the age, height, weight, and the computer can calculate the body mass index for this patient. And after that, this data for the patient, Ines entering the data of the patient for the computer. After that, the computer software can calculate what? Can calculate the predicted pulmonary function for the patient. Can calculate the predicted pulmonary function for the patient. After that, the technician can use nasal clips to close the nose. Hassan, the technician can use nasal clips to close the nose to do our in and out and flow from our mouth to be tight for the apparatus. After that, how many maneuver we can do by using this spirometry? By using this spirometer, we can do slow vital capacity maneuver, or named what? Expiratory relaxed vital capacity, and we can do forced vital capacity maneuver and maximum voluntary ventilation. You can start Ms. Ines. Nasal clips first for the patient. After entering the patient data, she can do nasal clips for the nose of the patient. After preparing the patient, after explanation the maneuver for the patient, she can start. You can start, Ines. During a slow vital capacity maneuver, the patient can breathe tidal. The patient can breathe tidal. The patient can breathe tidal. This is the tidal breathing. This is the tidal breathing. The patient can breathe this curve يا حسن, Mr. Hassan. This curve. The patient can breathe tidal. This is the forced vital capacity maneuver. The patient during the slow vital capacity maneuver. Where is the slow vital capacity maneuver first? Remove this one. And when we start by this slide, when we start, Mr. Hassan, again. Okay. When we start this tidal maneuver, the patient can breathe tidal. Okay, you can also when the patient start tidal maneuver. Yes, again, Hassan, to the computer. When the patient breathes tidal maneuver, this is the first, the tidal breathing, this is the tidal breathing, this is the tidal breathing, this is the tidal breathing. The patient breathes in and out. After that, he can take deep breathing and do the forced maneuver till the end of his expiration. From this curve in the slide, we notice tidal volume. The volume of air can be inspired or expired during normal quiet breathing. After that, the patient take deep breathing to the total lung air capacity. Deep breathing to the total lung air capacity. Deep breathing to the total lung capacity. After that, the patient can continue to exhale as continuous, as slow till the end of expiration. يعني some tricks. You notice that there is some flat here. You notice that there is some flat here. After that, the patient can breathe again as tidal labors. This maneuver is named what? This maneuver is named slow vital capacity maneuver. Slow vital capacity maneuver. We can detect from here the tidal volume, the inspiratory reserve volume, the vital capacity, slow vital capacity. This is part is expiratory reserve volume, and again this is the tidal volume. After the slow vital capacity maneuver, the patient can do this maneuver is named what? Forced vital capacity maneuver. The Miss Ines doing that this maneuver is the forced vital capacity maneuver. The forced vital capacity maneuver, we can notice that this is the expiratory limb and this is the inspiratory limb. Expiratory limb and inspiratory limb, when closed with each other, it is named what? It is named flow volume loop وليس curve. But this expiratory part is named what? Flow volume curve. And this inspiratory part is برضه named as a flow volume curve. But when this two curves crossing each other like this, it is named what? Flow volume loop. After that, we're doing how many maneuver? We're doing slow vital capacity maneuver. Slow vital capacity maneuver. This one. We can detect tidal volume, we can detect inspiratory reserve volume, we can detect expiratory reserve volume, we can detect slow vital capacity. Okay. After that, with me, Mr. Hassan. After that, this is the forced vital capacity maneuver. This is the forced vital capacity maneuver. We can detect the flow volume curve. So we have volumes, we have capacity. The volume is the smallest unit can't be divided. يعني the smallest unit can't be divided. But capacity is 2 volume or more. 2 volume or more. So what is the definition of tidal volume? It is the volume of air can be inspired or expired during normal quiet breathing. What is the expiratory reserve volume? It is the maximum volume of air can be expired from the end of what? Of normal expiration. But what is the inspiratory reserve? It is the maximum volume of air can be inspired from the end of what? Of normal inspiration. Okay, so we have now tidal volume, expiratory reserve, inspiratory reserve volume. We have now vital capacity and the functional residual capacity, total lung capacity, expiratory capacity, inspiratory capacity. When I am adding tidal volume to inspiratory reserve, it is inspiratory capacity. When I am adding tidal volume to expiratory reserve, it is expiratory capacity. The volume of air in and out from the lung, from total lung capacity to residual volume, it is named what? Slow vital capacity. It is tidal plus a two reserve, inspiratory reserve and expiratory reserve. Tidal volume is what? Volume of air 600 ml, 600 ml. Expiratory reserve is what? 1200. Inspiratory reserve 3000 ml. 3000 ml. Vital capacity is what? Is 4800. 4800. But the total lung capacity, when I have body box and calculating the residual volume, which is 1200, so the total lung capacity roughly it is about 6 liter. It is about 6000 ml or about 6 liter. So after that, I am doing forced vital capacity to detect what? To detect the forced expiratory volume during the first second. If everyone to detect the forced vital capacity. Yes, I have now slow vital capacity and forced vital capacity. It is normal person, the slow vital capacity equal the forced vital capacity, but can be different up to 5% vital capacity and slow vital, which is up and which is low. The slow vital capacity it is more than the forced vital capacity. But if the difference between slow vital capacity and the forced vital capacity more than 5%, so can detect, this can be done in COPD patient. I am detecting from forced vital capacity maneuver two important values. What is this two important value? FEV1 and the forced vital capacity. And I can detect a ratio FEV1 divided by forced vital capacity. So it is very important values to detect what is the pattern of my breathing, of my ventilation. We must have three important values. What is the three important values we need? These three values. FEV1, it is the maximum volume of air can be exhaled during the first second. Standard spirometer indices. These three indices is very important to interpret this pulmonary function. FEV1, forced expiratory volume in 1 second. The volume of air expired in the first second of blow. So the forced vital capacity is a total volume of air that can be forcibly exhaled in one breath. What is the ratio? It is the FEV1 divided by forced vital capacity. So this is the standard 3 value I can use to detect the pattern of ventilation. What is the number of pattern of ventilation? You know, simple according to spirometer only. What is the first pattern? What is the commonest pattern? Is the normal pattern. What is the commonest pattern? Don't forget the normal pattern. After that, you can detect a pure expiratory, pure obstructive airway ventilation, or pure restrictive airway ventilation, and mixed obstructive and restrictive. So, by using spirometer, I can detect first normal pattern, second obstructive pattern, third restrictive pattern, fourth mixed pattern from obstruction and restriction. How? How? What is this is the different pattern: normal, obstructive, restrictive, mixed, obstructive and restrictive. So criteria for the normal post bronchodilator spirometer. You must know all the value to be normal between 80% to 120%. 80% to 120%, except a division. A division of what? FEV1 للفورس vital capacity. It is named what? FEV1% or FEV1 ratio or FEV1 divided by force vital capacity. الكات اوف بوينت، الكات اوف نمبر اللي كان يوز، النمبر كان يوز فور كات اوف بوينت 0.7. 0.7. forget 0.8. forget normal predicted, but don't forget 0.7. above 0.7 it is either normal or restrictive. below 0.7 it is obstruction. It is obstructive but may be mixed, but it is obstructive. يبقى so أو الفيرست فاليو أو الفيرست indices I can read it if 1%. if above 0.7 it is mostly normal or restrictive. if below 0.7 it is either pure obstruction or mixed obstruction and restriction. What is the next index? Forced vital capacity, FEVC percent. It is above 80 or above and equal to 80 or below 80. FEV1 predicted above and equal to 80 or below 80. So normal values, البرسنت above, predicted forced vital capacity above, FEV1 above. Okay, so 3 indices up. 3 indices up, so this patient is normal. FEV1% above 0.7. الفورس فايتال كاباسيتي above 80%. FEV1 below 80%. طيب. Yes. If the 3 values below forced vital capacity percent below 0.7, it is either obstruction or mixed. Forced vital capacity below 80 and FEV1 below 80. So if the 3 indices below 0.7, 80, 80, so it is mixed pattern, obstruction and restriction. Mixed pattern. So now we diagnose 2 pattern simple. 3 indices up, normal. 3 indices down, below is the normal values. So it is either it is mixed. But if the FEV1% above, so it is normal or restriction. Forced vital, FEV1 above, but the FEVC below 80, so it is restricted. FEV1% below 0.7, but the forced vital capacity normal and the FEV1 below 80, it is obstruction. So we have simply to read what is the pattern of pulmonary function. Either normal, 3 indices up. Mixed, 3 indices down. Obstruction, the index is the most important index to diagnose obstruction. Is FEV1% below 0.7. So it is obstruction pattern. Either associated with mixed or not associated. Associated with mixed, يبقى الفورس vital capacity is below. The force vital capacity is below, but the obstruction FEV1 below. So يبقى they can detect. We can go to some example. This curve. If you notice this curve, what is this? Variable effort. Variable effort. the expiratory limb and inspiratory limb is hesitation for this curve. What is this? Early glottic closure curve. What is this? The patient coughing during during exhalation. خلاص. This is a different curve. You can read this curve and you can diagnose normal. You can diagnose normal. You can diagnose COPD by this sloping in expiratory limb. You can diagnose restrictive. You can diagnose fixed center upper airway. We have two curves, expiratory curve and inspiratory curve. Expiratory curve, if flat, meaning that introthoracic obstruction. I have thoracic inlet. I have thoracic inlet from here. I have thyroid swelling. This thyroid swelling is extra thoracic. So extra, inspiratory limb can be doing flat. If this thyroid swelling extended retrosternal and becoming pressure for the trachea above the thoracic inlet and below thoracic inlet, so the two curves will be flat like this, like this one. Okay, this symbol for diagnosis: intrathoracic obstruction, extrathoracic obstruction, or fixed obstruction. This one is fixed obstruction, intra and extrathoracic obstruction. This one inspiratory limb. So where is the site of obstruction? Is extrathoracic, thyroid swelling or other swelling, extrathoracic inlet. Okay, this one inspiratory limb and this one is expiratory limb. So it is meaning what? Meaning interthoracic obstruction. This is associated with airway obstruction. What is the airway obstruction? Asthma, COPD, bronchiectasis, cystic fibrosis, obliterative bronchiolitis, post tuberculosis. But you don't forget asthma and COPD. Two main causes: asthma and COPD doing airway obstruction. What is the disease associated with restrictive defect? Restrictive defect either intrapulmonary or extrapulmonary. Extrapulmonary in the thoracic KK, vertebral column, pregnancy from down, neuromuscular disease. But intrapulmonary, fibrosing lung disease, pneumoconiosis, pulmonary edema, parenchymatous lung tumor, and lobectomy or pneumonectomy. Spirometry diagnosis for COPD. What is the diagnosis for obstruction? If 1% below 0.7, so it is obstruction better. If 1 below 80, so it is sure obstructive better. How can you differentiate between asthma and COPD? By doing reversibility test. What can use it? Most common to be used salbutamol 200 or 400 microgram by using either inhaler or nebulizer. After 15 minutes or 20 minutes, I can measure again if FEV1. If improved more than 200 or if FEV1 improved 12%, يبقى short it is very important to notice that FEV1 increased by 12% and not or and 200 ml increase if FEV1. This simple algorithm to differentiate or to read pulmonary function. And thanks for all you for your interest. But this workshop, how to read I leave this for you to test yourself how to read the pulmonary function. This normal result, if 1% above 80, will if 1 above 80, will if 1 force vital capacity above 80, so sure if 1% it is above 0.7. Obstruction pattern ratio below 70, force vital capacity above 80, and if 1 below 80, so it is pure obstruction pattern. Like COPD والasthma والbronchiectasis والtumor والforeign body. Asthma or COPD, so you can do reversibility test. Ratio above 0.87, it is normal restriction. Force vital capacity below 80 will force vital capacity will FEV1 below 80. So what? So meaning what? Meaning is that it is a restrictive ventilatory effect with decrease in volume. Restriction disorder like kyphoscoliosis, muscle arthritis, neurolytic, interstitial, like this. Combined FEV1, FEV1 below 70, but 3 measures is below. You notice that ratio below 0.7, force vital capacity below 80, FEV1 below 80, so it is mixed or combined. Combined disorder زي severe COPD ومالتيبل pathological like kyphoscoliosis associated with COPD or tumor associated with COPD. And thank you for all of you.